Okay, I welcome you all to this webinar today, titled Emerging Researchers and Practitioners in Human Factors in Healthcare. This is organized by the International Economics Association's Healthcare Technical Committee. For those who don't know me, I am Dr. Adeola Bangboje Ayodele, a research fellow at the Digital Health Human Factors Research Group within the University of Sydney in Australia. The goal of this webinar series is to showcase excellent projects in human factors in healthcare done by early career researchers and practitioners across the IEA network. We define early career researchers and practitioners as PhD students and those who are within 0 to 5 years post-PhD, including career interruptions, or practitioners who have been working in human factors in healthcare for less than 5 years. The best presenter of the 2023 to 2024 webinar series will win the inaugural Richard Crook Prize, which is quite exciting. So far, we have done one webinar in the series, and this is the second one. But before I progress further, I would like to let you know that we do acknowledge the traditional owners of the land we are on in Australia. Therefore, I will like to acknowledge the traditional owners of the land we are all joining from. I am currently on the land of the Cabral people of the Darug Nation, and I pay my respects to elders past, present, and emerging. I am excited about the great presentations we have today, but before we continue, I would like to give a quick overview of this session and provide a few housekeeping rules. We have 3 presentations in this webinar. There will be 15 minutes for presenting and a 5-minute question time. Presenters will share their screen when it's their time to present. If you do have a question, please pop it in the chat. I'd encourage the presenters to respond directly in the chat for any questions that we don't get to during our discussion. Please note that the webinar is being recorded and will be uploaded to the IEA's YouTube channel, but only the presenters and the organizers will be visible on the webinar recording. Now, without further ado, I would like to introduce our presenters to you. First up is Dr. Kirsty McLeod. Kirsty is a registered psychologist and a senior research fellow at the Clinical Skills Development Service, Royal Brisbane and Women's Hospital in Queensland. Kirsty received her PhD and Masters of Organizational Psychology from the University of Queensland. Prior to her current research position in healthcare, she worked as a human factors consultant across all other high-risk industries, including aviation and air traffic control. Today, Kirsty will be presenting on a human factors approach to optimizing laparoscopic skills training. Can you please share your screen, Kirsty? Over to you.
Great, thank you very much, Adeola. I'll just share that now. Is everyone able to see that?
Yes, perfect.
Fantastic, great, thank you. Thank you, everybody. My name is Kirsty McLeod, and thank you for listening in today. Okay, so to start off the session, I'm going to be walking you briefly through a program of research that I conducted here at the Clinical Skills Development Service, or CSDS as we like to call it, looking into the optimization of laparoscopic skills training from a human factors perspective. So to conduct this research, I collaborated with and received support from various specialists across a number of fields, including cognitive psychology, visual perception, social psychology, human factors, medicine, and of course, surgery. And for those of you who may not know too much about this area, laparoscopy is a surgical technique that's often referred to as minimally invasive or keyhole surgery. And it's currently considered the gold standard approach for a range of surgical treatments, largely because of its minimally invasive nature and the smaller incision points that are used that can mean faster recovery time for patients, reduced risk of infection, and shorter periods of hospitalization. But despite the many benefits associated with these techniques, there are also several problems with the learning of these minimally invasive skills. First, research has shown that up to 80% of all major laparoscopic complications that occur, and this can include permanent injury or fatality of a patient, occurs early on in a surgeon's career, often within their first 100 cases. And when we talk to surgical directors, we also find that they've been reporting that many surgical residents or registrars are coming into the OR unprepared, with approximately one third being unable to laparoscopically manipulate tissue without causing damage, and approximately one half being unable to suture laparoscopically. And when we look at training, research has also shown that up to 20% of trainees are unable to overcome the challenges involved in training and fail to reach baseline proficiency levels in laparoscopic skills, regardless of continued practice. So, why might this be? Well, when we look at what's required to learn these minimally invasive skills compared to open surgical techniques, we find that there's quite a few unique psychomotor challenges involved. So, for example, the use of small incision points, often in the abdomen, constrains the surgeon's range of motion and movement. The use of these small incision points and ports that they use to insert the instruments also requires counterintuitive movements, which is often referred to as the fulcrum effect, and it could be likened to working backwards in a mirror. So, if the surgeon wants the end of the instrument to move to the left, they have to move their hand to the right. And the use of these long surgical instruments also reduces tactile feedback that we obtain through direct touch. So this makes it quite difficult for the surgeon to judge the texture and force of an object or know how much pressure to apply. And then the use of a small camera and the traditional 2D display to view inside the body means that there's a loss of 3D depth perception, making it difficult for the surgeon to judge distance, to orient themselves, and to navigate easily. But despite these psychomotor challenges, there's been a real lack of research into how to overcome these skill deficits and optimize the skills learnt during training. So, the aim of this research program that I did here was to address the gaps in both research and practice and to identify ways to optimize the learning of laparoscopic skills during training. And by learning, I mean the acquisition of the skills during the training period, but also the retention of those skills or the ability to recall them and use them in the long term, and the ability to transfer or generalize those skills to different contexts and situations. But given the multifaceted nature of laparoscopic skills training, I designed a program of research using a human factors approach, which involved looking at how the work environment and systems fit with the people that are using them. So while this obviously could extend into higher level team and organizational factors, in this research, I explored how the design of the training environment, the equipment and technology, and the tasks and the processes meet with the capabilities and limitations of the individuals interacting with them. So I started by reviewing the literature in each of these areas to reveal key concerns and explored unanswered questions to guide the focus of my research. So to begin, I started exploring the training environment. And when we consider open surgical techniques, we find that the traditional apprenticeship style approach is still commonly used to teach the necessary skills. However, due to the innate challenges involved in even the most basic of laparoscopic tasks, training is conducted in a simulation based environment to avoid unacceptable risks to patient safety. So, to conduct this research, I created this high fidelity simulation training environment here at CSDS, as you can see pictured, using a standard box trainer and surgical instruments. So, in this first phase, I started exploring the type of equipment and technology in use in the laparoscopic environment, focusing on the elements that presented the greatest challenges to surgical practice and performance, which is namely the visual display. So, while 2D displays are traditionally used in laparoscopic surgery, recent innovations in technology have seen the introduction of 3D displays. And while there's research to suggest that the increased depth perception associated with these displays can help to reduce training challenges and therefore improve learning outcomes, the research has been extremely flawed. So, for example, many of the papers haven't, or the research hasn't looked at perceptual confounds associated with the use of 3D displays, and none of the research had actually employed any control groups. So, in my first study, I randomized medical students to different training and testing conditions with 2D and 3D displays and addressed the limitations of past research. And in line with expectations, I found that training with a 3D display did produce more efficient performance than with a 2D display. However, with this study being the first of its kind to employ research controls, I was able to show that there was no difference in retention or transfer performance between those trained in 2D or 3D. So what this meant is that there was no difference in the overall level of learning between the displays. What this finding really reminds me is that there's still a common misconception that training automatically leads to learning, but this isn't necessarily the case. Real learning isn't about how well we see a trainee repeat the task back at the end of the training session. It's about how well they can retain and apply those skills over time, and then how well they can transfer the skills to other contexts, and most importantly here, the real clinical context in the OR. Otherwise, what's it all for? So, in this next phase, I looked at motor learning theories from other contexts and then reviewed how the tasks and processes used in laparoscopic skills training were being employed. What I found in this review is that laparoscopic skills training largely followed a traditional approach. And this is where you can see here on the left, where practice is conducted in a mass format like all-day workshops with specific set tasks, practiced in blocks and in set orders. However, evidence-based learning strategies and theories suggest that introducing more interference into training, such as spacing out practice sessions, varying the tasks and other contextual factors, and presenting them in a randomized way, has much greater effects on learning than a traditional approach. Unfortunately, these strategies can feel quite counterintuitive as they invariably impair performance during training due to the increased complexity involved, but they can improve the skill retention and transfer as they require more complex processing during that training period, which then strengthens that ability to recall and generalize those skills and helps those trainees build greater mental representations of those tasks. Unfortunately, these strategies, though, are rarely applied in clinical skills training despite their potential. So in this next study, I randomized medical students again to high or low levels, but this time to high or low levels of visual interference, so like randomized versus controlled visual displays during laparoscopic skills training. And in line with the expectations, I found that trainees with low interference were more efficient during the training period than those with high interference. But those that trained with high interference generally performed more efficiently in retention and transfer tasks than those who trained with low interference. I will, however, note here that the differences in the retention and transfer of performance were only approaching significant, likely due to the limited sample size. But the overall trends align with the theory and research that suggests that increased interference in training may impair initial performance, but may help us to increase overall learning, which is what we're really looking for. So, though, when we look beyond the environment and the technology and the processes, we need to remember the humans that are interacting with them all. Unfortunately, the surgical literature has often overlooked the individual or focused solely on innate abilities like manual dexterity as the key to superior laparoscopic skills. However, the results remain largely inconsistent as they overlook the complexity of human performance. So, in this next phase, I started exploring the individual capabilities that have been associated with complex motor performance in other high stakes fields, both across clinical and non clinical areas. So, in this next study, I measured medical students' baseline physical ability, so things like manual dexterity, cognitive ability, so things like visual spatial ability, their visual abilities, so visual acuity or stereo acuity, or their ability to see in 3D, and also psychological skills, so variables such as psychological flexibility. And then again, assessed various aspects of their performance in laparoscopic skills training. And while I found that each of these variables were associated with performance or significantly associated with performance in some way, psychological skills were actually the greatest predictor of performance in laparoscopic skills training over and above the effects of physical, cognitive, and visual abilities combined. So while the psychologist in me got very excited here about what was sort of an unexpected finding, I thought, well, this is great, but what can we do with this information? What this finding really reiterated to me was that how someone thinks predicts how they'll perform. And a perfect example of this is the well-known effects of high stress on all kinds of performance. However, when we look at the stress literature, I thought it was quite interesting that there's a lot of research linking stress to performance outcomes. And also to, explain how stress impacts performance, so through things like decreased attention. But there wasn't much, if any, to explain why people perceive stresses differently in the first place. What I wanted to really understand here was why one very physically and cognitively capable surgical trainee can see a potential stressor as threatening and become anxious and overwhelmed and then perform suboptimally, while another equally capable trainee might see the same stressor as a challenge and feel excited about it and perform optimally. So, this gap in understanding led me to seek a deeper exploration into the effects of stress and high demands on performance in this next phase. So, in this next study, I measured various cognitive, physical, visual, and psychological variables of medical students again, and again measured their technical performance on laparoscopic tasks. And what this research revealed was that there was distinct psychological precursors to stress. So, to explain this a bit more, both stable and temporary psychological variables, or what we could say is someone's mindset, predicted how stressful they perceived the laparoscopic skills training to be. So this was before training, or how they perceived they could cope with the upcoming task. And it was this perceived evaluation or perceived ability to cope that was the greatest predictor of technical performance on the laparoscopic tasks, and also the greatest predictor of how they responded to it or how anxious they felt during the training period. And this was above all other variables, including physical, cognitive, and visual abilities. What I find most interesting about these findings is that they can help us to explain why surgeons with the same physical and cognitive abilities and at the same level of practice and experience can perform in such different ways. It also helps us to explain why things like stress management training can have positive effects on performance, but why it doesn't always work for everybody, or at least at the same level. So, if we can better understand these mechanisms, though, we can start to tailor stress management training to suit the needs and constraints of the individuals. And while I acknowledge that this can take more time and effort to do so, improvements in this context could mean the difference between the life and death of a patient under a critical situation or the well-being or burnout of a surgeon over the long term. Okay, so just to summarize a few key points and takeaways from this research here. First, 3D displays did not increase the overall learning of laparoscopic skills. So it's important to remember that new technology isn't always the answer it's cracked up to be. Performance in training doesn't always mean that real learning is occurring, and we need more applied research to explore the effects of increasing interference and other learning theories in training curricula to increase the overall learning of skills. Psychological skills are just as important as physical, cognitive, and visual abilities for laparoscopic performance, if not more so. As a result, we need to stop passing them off as soft skills or non-technical skills alone. Rather, we need to holistically address these variables in our research to better understand and be able to support the technical skills of our clinicians. Lastly, adapting stress management training to address the antecedents to stress may help us to optimize the learning of laparoscopic skills with far-reaching implications for our practice. We may also use this knowledge to adapt the training environment, the equipment, the technology, and the tasks and processes to foster these psychological skills in that training period, rather than overlooking them and placing our trainees in highly variable, unpredictable, and high-stress contexts without adequate preparation. And I think these words by Richard Cook really just, I guess, reiterate this final point that I want to make, in that all practitioner actions are actually gambles. That is, acts that take place in the face of uncertain outcomes. So it's no wonder then that we find that the ability to psychologically adapt, become resilient to change, uncertainty, and potential failure can lead to optimized performance in high stress contexts like surgery. Okay, that's it. So thank you very much, everyone. Any questions?
Perfect. That was a fantastic presentation. Thank you so much, Kirsty. If you have any questions in the chat, or if you have any questions, please just pop it in the chat or let me know. While people are thinking of questions, I think I might ask you a few questions, if you don't mind. You did mention that psychological skills had a greater impact than, physical and cognitive and things like that. Now, so what do you think about self-efficacy? Do you think it impacts performance in this context?
Yes, so self-efficacy is overlaps, I guess, quite a bit in terms of psychological flexibility, which was that main psychological variable that I found was the greatest predictor. So it is that sort of, I guess, self-belief in that you have the resources to be able to meet the demands of the upcoming task. And so that sort of self-belief, obviously, and that self-confidence is definitely part of that psychological concept of a flexible psychology.
Thank you. And I don't know whether I missed this in your presentation, but what were the performance indicators used in your study?
What was the
The performance indicators.
The like actual measurement tools?
Yes.
For the psychological variables or
for the performance of the
Oh,
individuals. Yeah.
oh, sure. Yes. Yeah. So the physical performance on the
Yes.
tasks.
Yes.
So they were given a proficiency based training period. So they had sets. So I think in most of them was 5 to 6 tasks that they had to reach a baseline proficiency level, and that included time and errors. So we followed what the fundamentals of laparoscopic surgery, which is a sort of worldwide validated training program, and we followed those set tasks to the point where they were able to reach those proficiency levels. So that could range from, for some students, it might have been 2 attempts, and for some, it could have been 220 attempts. So yeah, it was quite
Great.
varied.
Thank you. Yeah. And what benefits could this research have for other clinical contexts?
I think it has a pretty broad benefit for other contexts. First off, I guess it really shows the importance of human factors in any, I guess, performance and in any clinical skills, that we can't just say, I guess, blame people or blame tools or, something. It's that kind of holistic, combined interaction that can cause this. But in terms of the actual value, I think the last couple of studies in terms of the psychological skills that really seem to have a huge effect on performance, knowing that and being able to develop, which is ideally something I'd like to do in the next few years, is develop sort of some training measures around that. And I think that's something that we could definitely employ in other clinical contexts, because they're invariably very high stress. So
Thank you. Oh, so we have some questions coming in. The first one is, what do you think it will take to encourage a shift in healthcare training to the kind of strategies that you're suggesting?
I think it would take more research in this space. So everybody loves data, and I think, yeah, we need more evidence to be able to really back this up. There is, and there's been a real kind of shift to that over the last few years, but it's still in its infancy. So I think that's what we really need to focus on now, and that's kind of one of my main priorities. So
Great.
yeah.
Thank you. We have another one from Simon. Thank you, Simon. Simon says, very interesting and clear presentation. Thank you. Do you have any ideas of how to train the mindsets of surgeons?
Well, when we look at psychological flexibility as a construct, it's closely linked with mindfulness. And there are surgeons out there that do practice mindfulness, and they make their teams practice mindfulness before surgery. But it's actually, as a construct, it's linked to ACT, so acceptance and commitment therapy. So there might be, I guess, elements that we might be able to use from that type of therapy that's not used in, I guess, an occupational sense, but we might be able to, say, adapt that kind of therapy and use it as a bit of a training tool in this context.
Perfect. Thank you so much, Kirsty. I'll give you a round of applause.
Thank you very much.
All righty. And we're going to progress to our next presenter. Next, we have Natalia Ransolin. Natalia is an architect, an urban planner, and she recently submitted her PhD thesis in civil engineering at the Federal University of Rio Grande do Sul in Brazil and at Macquarie University in Australia. Our thesis focused on the influence of the built environment on the resilient performance of daily workflows in healthcare settings. Natalia investigates topics such as complex socio-technical systems, human factors and economics, resilience engineering, healthcare, built environment, and evidence-based design. She's currently working as a postdoc at the Australian Institute of Health Innovation with Professor Robin Clay Williams in the Human Factors and Resilience stream. Today, Natalia's presentation is titled Built Environment for Resilient Performance in Health Services. Can you please share your screen, Natalia? Over to you.
Of course, thank you. Are you seeing my screen?
Yes, perfect.
Okay, so I'll just, okay. Good morning and good evening for everyone. It's a pleasure to participate in this webinar series. This presentation is based on my PhD thesis titled A Framework of Built Environment Design Knowledge Supportive of Resilient Internal Logistics in Hospitals, my most recent work. This thesis has been conducted under a call-to-tell scheme and supervised by Professors Tarcísio Saurinho and Carlos Formoso at URGS in Brazil in civil engineering, and Professors Robin Clay Williams and Francis Rapport at Macquarie University in Australia in health innovation. And I submitted my thesis to both universities in November this year. Now I'm working as a postdoc in Robin's team. The background of this work is based on the characterization of the healthcare as complex socio-technical systems. These systems are composed of many human, technical, and organizational elements in dynamic interactions. We focused on the interactions of stakeholders, such as providers, caregivers, patients, and families, with the built environment. More specifically, the influence of the built environment to resilient healthcare. Healthcare are environments that should be designed as part of complex socio-technical systems to facilitate adjustments to everyday variability and resilient performance, which is a functional property of those systems. Resilient performance has been investigated across the macro, meso, and micro levels of healthcare, that is from healthcare systems to hospital units. So this thesis assumes a systems perspective to analyze the relationship between the built environment and logistic flows, intra and inter-hospital units. Hospital internal logistics involve the handling, transportation, and storage of materials and equipment to fulfill patient care requirements at the right time and place. These activities are constrained by the built environment. For example, in the choice of roads and transportation of equipment or walking distances. So the research question guiding the thesis was, how can we develop built environment design knowledge supportive of resilient internal logistics? This question was addressed by a framework of built environment design knowledge supportive of resilient internal logistics. For that, 3 papers were produced. The first paper was a systematic literature, which is already published in HERT. The second paper focused on the common areas that involve flows to and from intensive care units and is under review in applied ergonomics. And the last paper was developed on the internal logistics of a surgical service and has been submitted to engineering, construction, and architectural management. Case study was the research strategy adopted to answer how questions on papers 2 and 3. And data collection counted on document reading, observations, meetings, and walkthrough sessions. Semi-structured interviews were conducted to investigate the everyday work of hospital units, emphasizing the role of the built environment. Overall, more than 130 hours of empirical data were collected on the thesis. I will present the main findings from the first paper, the built environment influence on resilient healthcare, a systematic literature review of design knowledge. So the theoretical foundations we adopted were the 5 guidelines for coping with complexity. Since in complexity, in complex socio-technical systems, the variability is part of daily work, Resilience is a feature that arises to deal with unexpected events, and it could be engineered by the 4 resilient potentials from Honeywell, which are respond, monitor, learn, and anticipate. The ultimate goal of applying these guidelines is to create an environment that supports resilience. We used PRISMA method to select papers, and firstly, we have identified more than 2,000 papers from 7 databases plus manual inclusions. And after scanning, the final number of papers included for full text reading was 43. The results of this work focused on design knowledge that arises from the analysis of papers based on the 5 guidelines for coping with complexity. 21 design prescriptions with corresponding 58 practical examples were devised and distributed into 7 design principles and meta-principles. Those meta-principles were related to the complexity guidelines, and design principles were the translation of those guidelines to the built environment field. And this knowledge was applied in the following case studies of papers 2 and 3. So the second paper of the thesis is Built Environment Design Knowledge, Supportive of Resilient Performance in Hospital Internal Logistics. Hospital internal logistics occur in the connecting areas of hospitals, such as corridors and elevators. In this sense, the built environment should support a smooth flow of logistics. This is important because patients may need care during their transportation. And when standard roads are blocked, or in cases of sudden surge of demand, the built environment plays a key role in supporting resilient performance. This study is concerned with the transportation and movement of people and supplies between hospital units in the common areas that involve service flows to and from an intensive care unit. These common areas are referred to as CICU areas. So CICU areas include corridors, roads, elevators, and the pneumatic tube system of the hospital. The setting of this study is a large public teaching hospital in Porto Alegre, southern Brazil. This study focused on 2 13-floor interconnected buildings. Building A accommodated the study ICU for several years and still composes parts of the CSU areas. And this diagram represents the built environment design knowledge levels and their connections. So the design principles from paper 1 were used for thematic analysis and gave rise to 7 design prescriptions that are the main core of this knowledge. At the lowest abstraction level, 63 practical examples were generated. To illustrate their applicability, this table shows how the design prescriptions were presented, listing the respective practical examples according to the corresponding hospital internal logistics flows of people and supplies. For example, the prescription of give visibility to flow interferences, obstacles, and risks is represented by installing mirrors in the corridors, crossings to ensure the visualization of incoming flows, which is associated with all flows. The 7 design prescriptions were applied in the following case study. The last paper of the thesis is Beyond Operating Room, Built Environment Design Knowledge Supportive of Resilient Surgical Services. So surgical units are complex settings demanding the articulation of several human and technological resources under uncertainty and efficiency pressures. Surgical supplies and staff from several locations must arrive on time and be the correct type and number. And the built environment needs to be flexible enough to cope with a wide range of clinical procedures while facilitating the setups of operating rooms. It also must be based on inputs from a variety of professionals, not only from those who spend most of their time inside operating rooms. So the surgical unit investigated in this paper is located at a private teaching hospital in Sydney. The complex is a 5-floor building. Elective surgeries are performed on the first floor across 13 operating rooms. The floor plan of the surgical service was divided into perioperative areas where patient flow occurs, from patient admission to discharge, and support areas where the internal logistics occur. From the total area of the service, 21% corresponds to the operating room, while 61% corresponds to supporting areas. These numbers should highlight the relevance of logistics activities from the built environment design perspective. We grouped the 8 previously presented surgical flows and consider 6 types of flows: patient and family, sterile instruments and materials, waste, staff, equipment, and supplies. These flows were represented in the floor plan according to their directions, as some flows cannot be bidirectional. The spaces of perioperative and support areas were distributed into unrestricted, semi-restricted, and restricted areas. Circulation accounts for 34% of the floor plan, again highlighting the relevance of the logistics for built environment design. In this study, the 7 design prescriptions from paper 2 were used for thematic analysis and categorization of 60 practical examples. I will present an overview of each prescription, followed by one practical example just to illustrate its application. Similarly to paper 2, the design prescriptions and practical examples were presented according to the corresponding flows. Here, we also associated the examples with the areas. Firstly, the prescriptions of design safe, efficient, and flexible roads between perioperative phases is illustrated by complying with corridor dimensions for clinical areas to fit the larger ICU beds. Assess the pros and cons of centralization and the decentralization of resources is exemplified by the location of scrub bays, which can be shared between up to 2 operating rooms if centralized. Similarly, depending on location, induction rooms can be shared and coordinated between operating rooms. The prescription of give visibility to flow interferences, obstacles, and risks is illustrated by visual demarcations, such as red lines on the floor to avoid people crossing into restricted areas. The use of visual management for identifying spaces, resources, and processes can be exemplified by the setup of case cards. Nurses can attach the preference cards containing the list of surgical items to the card to indicate the scheduled surgery and its corresponding operating room. Provide slack resources to cope with disruptions is a prescription that can be represented by planning multi-use spaces. For instance, patient bays next to the intraoperative area can be converted into operating rooms or temporarily used as storage. The design for the prevention of infections and contamination is exemplified by operating rooms with enough space for maneuvering without contaminating the instruments and the sterile field. For that, the sterile boundaries can be made visible by LED lighting on the ceiling and colors on the floors. Lastly, the prescription of technology supportive of safe, efficient, and flexible workflows is illustrated by call systems with buttons inside operating rooms to indicate that orderlies and clinical staff are needed. Similar device could be implemented to communicate to the surgical team that the patient that is waiting in the induction room is ready to enter the operating room. The research objective of this thesis was to propose a framework of built environment design knowledge supportive of resilient internal logistics in hospitals. At the 2 highest abstraction levels, the framework comprises 4 meta-principles based on complexity theory and 7 principles that provide design guidance to a built environment supportive of resilient healthcare, not specifically to hospital internal logistics. These elements were generated in the systematic literature review and were preserved in the following case study that focused on design prescription and practical examples at lower abstraction levels. And the proposition is that the same research method used in papers 2 and 3 can be replicated to produce design knowledge for resilience in other hospital areas. The framework is our original contribution expected to guide the built environment and hospital operation designers. The framework is also fractal in the sense of being relevant to the micro, meso, and macro levels of health services. At the micro level, the design knowledge was developed for the internal logistics of a single hospital unit, the surgical service, although also considering the implications for the meso level when discussing the interactions with other hospital units. At the meso level, design knowledge was devised for the logistics activities to and from intensive care units. And at the macro level, the framework can be used for the identification of regulations most supportive of resilient healthcare. There are logical relationships between the design knowledge and the four potentials for resilient performance. For instance, practical examples that suggested using digital wayfinding to track flows in real time can be associated with monitoring the conflicting flows. Anticipate can be associated with conducting mock-ups to verify crossing flows in practice. So that's it. Thank you very much for your attention, especially the Healthcare Ergonomics Technical Committee and Adeola for chairing the session.
Thank you so much, Natalia. That was a fantastic presentation. Thank you. If anyone has any question, could you please pop them pop your questions in the Q&A. In the meantime, I will ask some questions. First, Natalia, was there any suggestion in the literature on how we can make the business case for Slack? Because you did mention Slack designing. Yeah.
There is a author from the 80s. His last name is Borges. I don't know how to pronounce it. It's French, but he wrote about Slack in the business management field. We adopt this literature to include in the 5 guidelines for complexity. So designing Slack is a way to support flexibility. So Slack can be opportunistic. So it can be planned in advance. So you can plan the Slack. So you can have, for example, in the build environment, you can have bigger rooms when you don't know exactly which patients are coming and being admitted, or you can have opportunistic Slack when you, for example, you have 2 rooms and a sliding door between them, so you can use at the same time those 2 rooms, but you can also expand them if needed. So there are different types of Slack, and then we translate it from the business to the managerial construction management approach. Yeah.
Great, thank you. Thinking about COVID-19 now, do you think there was any impact of COVID-19 procedures on flow, like the patient flow, waste flow, things like that?
Yeah, there were a lot of impact, and I think this question is very interesting because it relates to some other questions that I received previously in other presentations where people asked me if I could apply that knowledge for existing buildings. So I think when you have already the building, it's difficult to try to apply different ideas and knowledge. But when you have, for example, pandemics and different disasters that you need to change the infrastructure of the hospital, you need to prioritize the flows, which was the case of the COVID. So we did like a lot of hospitals, they created committees to establish what were the pathways of the COVID-19 patients to separate and mitigate the dissemination of the virus across the hospital. So yeah, you need to start addressing what are the priorities of the knowledge in the circumstances that you are facing or the challenges you want to be resilient against.
Right. So how do you think designers can sort of be trained to use this knowledge and the framework you've come up with?
Yeah, I think designers, like especially architects, we need to be more familiarized with human factors principles, because although we are very familiarized with practical and physical ergonomics, we lack the understanding of human performance in the systems. So I think when you have like architects to conduct case studies and be interacting with the customers of the project, of the design, it will help a lot to create sense of how people should conduct this knowledge into practice.
Right. So in thinking about, governance now, regulations and standards and things like that, do you think it's possible to sort of incorporate the design knowledge for resilient performance in regulations and standards? What do you think is needed to make that happen?
Yeah, that's a tricky question, because regulations, they talk about resilience, but they don't talk about, they talk in more like it's a flexibility. It's something like it's not explicitly addressed. So I think we should talk to regulators in a more horizontal way to try to interact with the way guidelines are being provided, like having sections that talk about human performance inside like construction guidelines.
All right. Thank you so much. Any other questions? There's one coming up. Okay. So we've got one from Victor. Thank you. It says, Natalia, this is a very interesting presentation indeed. How does resilience logistics impact occupational health related incidents in a complex health services system?
Okay, that's a good question. Although we didn't address it explicitly, the occupational health, it's pretty much associated with this field, because the aim of applying a built environment that is resilient, it's to support the workers in their daily work. So we are talking in resilience in the everyday work, so variabilities that occur all day in every day, in daily basis. It's not a disaster. So the idea is to promote, for example, better wayfinding, better conditions, better work conditions, for example, in the shelves of the storage rooms near the surgical units. There are lots of heavy items that are placed under the shelf, so it's difficult to assess. So all these kind of things will impact the work conditions, and of course the occupational health as well.
All right. If there are no questions, I would like to say thank you so much, Natalia, for that presentation. And we will move on to our next presenter. We have Dr. Yuan Chai. Yuan is a research affiliate at the University of Sydney. He obtained his PhD from the Australian National University. His research interest includes 3D printing, artificial intelligence, and medical imaging. Today, Yuan's presentation is titled Quantifying Landmark Annotation Accuracy on Radiographs Using a Probabilistic Approach, Measuring Pelvic Teeth as an Example. Can you please share your screen, Yuan? Over to you.
Yeah, sure. Thank you very much. Everyone see my screen now?
All good.
Cool. Hi, everyone. I'm very glad to present my study as an IEA webinar. Today, I'm talking about a probability-based method of evaluating the accuracy of radiographic landmarking. So my talk will go through the standard talk points, introduction, methods, results, and future studies. Firstly, let me introduce my study. So as you may know that when a patient see a surgeon and surgeon decided to proceed with the surgery, usually the patient need to go and take radiographs so that the surgeon can evaluate radiographs to determine the optimal size, brand, and the location of the implant. So I have a very quick animation to show how different the skeletals between patients. So let's have a quick look. Yeah, so as you can see here, even though these skeletons are similar sizes, but it's deviate largely between people. So this is why we need a personalized evaluation of, say, landmarks. So traditionally, the surgeons may use, say, a ruler method to measure the lenses or angles on the paper film, paper radiographs. And now we use the electronic films more, and then we just click on the points, the pixels on the screen, so that the computer can calculate the parameters by pairing the landmarks together. And even more recently, we have AI method to automatically annotate the landmarks, which reports the outcome in heat map format in confidences. So what we measure, so usually we measure the lenses or angles of the patient to determine the optimal implant size, orientation, location. However, you may know that these landmarks are defined ambiguously. We define a landmark based on a region or an area rather than a ground truth pixel. So during the landmark annotation, we may have systematic error due to cognitive differences. Because some surgeons might think this is the correct area, but some other may think that the correct area might deviate from that. So we call it cognitive differences. And also random error, even though the surgeons agree that this is the correct place, but they can still generate some noises in between. So which one would be the best point? We don't know yet. So currently, we can only evaluate these errors based on a pair of landmarks. So we report the errors in mean absolute error, root mean square error, or correlation coefficient. So we only analyze it at a parameter dimension like the angle or length. However, if we look at the AI outcome, AI always report its outcome in a heat map format at a landmark dimension, at a point dimension. They report at a point what confidence the AI could be at this pixel. So actually, we don't have a method to evaluate the human outcome at a landmark dimension. So when we compare errors between human and AI, they are actually not communicating at the same dimension. So the aim of this study is to establish an easy-to-use method that quantifies landmark accuracy in clinical practice, which we need to take into account the imperfections of manual landmark annotation and ambiguous landmark definition as well. So the method, in this study, we proposed a method to reach our goal, and we designed a study to validate this method. So let me quickly introduce you the method we want to propose. So here we say multiple observers annotating the same landmark on the same image. The centroid of their annotations, which is the average location, we say this would be the best pixel to represent this landmark. But between patient or between images, we can have different resolutions, different sizes. What can we do? So we propose to use a length parameter as a scaling factor so that we can scale all the skeletons to a similar size. And when they reach the similar size, we superimpose all the centroid location of each landmark so that we can see all the landmark distributions of the same map. And from here, we can calculate the probability distribution. And finally, only the distribution as the orientation of interest will be important. I will explain this later with a very practical example. So here in our study, we use the measurement of pelvic tilt as an example. We have two definitions here. On the left-hand side, it's an anatomical definition. We annotate 2 points plus the gravity line. The vertical line, we can have an angle, and also the other definition, right-hand side, mechanical definition, mechanical pelvic tilt. We annotate the center of femoral head and center of sacral slope. So these two lines, these 2 points organize a line plus the gravity so that we have the pelvic tilt angle. So for these 2 points, we can either estimate the center location, or we annotate the edge as the computer calculates the center for us. So we actually did 2 methods in our study. So these are the landmarks that we need to annotate in our study. So in our study, we recruited 115 lateral radiographs for the annotations. So in this study, we evaluate anterior-posterior tilt rather than the other way by rotation. So in our study, we recruited 5 observers to annotate all the landmarks. And for the mechanical definition, we have 2 different ways: by estimating the location, or annotating the edge and calculate the location. So after all these annotations are done, we had a secondary review of all the annotations so that we can identify the outliers and why they're outliers, and whether they are outlier in an acceptable way clinically. So finally, we had a statistical analysis. We want to know the reasons of these outliers, and also we want to calculate the probability distribution of all the landmarks and their impact on our parameters. So as I mentioned before, since we have at least 1 pair of landmarks, so we have a line, the size could be used as a scaling factor to scale all the skeletals to a similar size. Although it's a rough method, it's an estimation method. So after they are at a similar scale, we superimpose their centroid to visualize all the landmark distributions. So once we superimpose them, it looks like this. Remember, I mentioned the orientation of interest. So here in this example, the orientation perpendicular to the average pelvic tilt angle. Here, landmark 1, landmark 2 will be the orientation of interest. So basically, we project those distributions to the orientation of interest, so that we have a one-dimensional density distribution. So this density distribution impacts most on the landmarks, the angular measurements, the theta max here. So we want to know that while this cloud size, how large it is, and what's the maximum impact on the theta max. So let's have a look at the result. So even the traditional statistics, like interclass correlation coefficient, if we look at our data sets, we can see that all the ICCs were above 0.9, which statistically we say that all our measurement reproducibilities were regarded as excellent. So they're all great measurement. And also we had averagely 1 to 2 degrees error between measurements between observers. So this serves as a clinical error standard, which is pretty okay clinically to use these data sets. However, use our method to further look into these data sets, we can see that at least 60% of cases, we have 1 landmark were regarded as inadequate. They are outliers, and whether they are acceptable outliers, no. Over 60% cases contains this kind of inadequate annotations, which can be identified by secondary review. So this is already very high. And if we look at the density distribution, cloud distribution here, remember we superimposed all the centroid, and we can visualize all the annotations on the same map. So here's the outcome. So let's focus on this point first, PP point, which is this point, pubic tubercles. So we can see that the green dot, one of the annotators, consistently annotated the inferior end of the pubic tubercles, while the other observers didn't agree with that. So here we can see what we meant cognitive differences here, because this surgeon might be trained differently from the other surgeons, and they never know. And this is information that the traditional statistics won't tell us. And also, if we look at the points starting with PS, sacral slope. Here we can see every of them contains some extreme outliers here. So what happened to these annotations? Why there are extreme outliers? So by further looking to these patients, looking into their radiographs, we identify that this patient has kind of disease around this region, either lumbalization or sacralization, which means this vertebra fused on the sacrum, so they stick together, which means we were a little bit difficult to identify whether we should annotate this area or this area. So this made it wrong, and it can be identified directly from our method. And this was usually overlooked by traditional method. Remember, using traditional way, we say these measurements were excellent. And now we can quantify all these measurements. So here we can see probability distribution, like 5% data set, 50%, 95%. What's the cloud diameter of each point? And what's their maximum impact on the angular measurement here? So what does this mean? It means that, for example, at 95% data sets, we excluded 5% extreme outliers already. We can still reach like 9.5 degrees and 16.5 degrees maximum differences between the measurement, which is quite high and high enough to change clinical decisions. And this is on this figure, I highlighted a few data here. So 50%, 75%, 95% data sets, what's the cloud diameter, and what's their maximum impact on the pelvic tilt angle measurement. So from here, we can compare the human outcome to the AI outcome at the same dimension, at a landmark dimension. So remember, we showed this study in the very beginning. So we evaluated the same landmarks, and the AI reported accuracy at 50% confidence, 75% confidence. But comparing to a doctor outcome, a doctor is still way better than the AI because at the same confidence level, the doctor can focus on a smaller region, which means that we should not use this AI to replace doctor on this landmark. Similarly, on L5, a doctor outcome still better than AI. So in conclusion, using our benchmark dataset, we should say that it's not recommended to use this AI model to replace the human method to annotate these landmarks. So similarly, some other AI methods reported their mean +2 SD outcomes. And comparing to our doctor outcome at 95% data points, the doctor is still better than the AI performance. So this AI could not be used to replace the clinical practice. So finally, we had a device to measure the same landmarks, which reported a maximum error better than the doctor outcome. So this study used a cadaver to conduct the experiment. So we can see that if we can replicate a similar error to real patient using the same device, there's a high potential to use this method to replace the doctor outcome. So future studies, of course, we want to evaluate more patients, incorporate more anatomical changes, and also if we have more observers, we will have a more objective ground truth point for each landmark. And also in this study, we only evaluated the 2 pelvic tilt definitions. If we can have more and we can collect all of them on the same database, and then we can use this database to evaluate the landmark annotation method of using other method other than human. So to do this, we've already established a study website so that we currently shows the outcome of our study. So in the future, we hope we can incorporate more landmarks so that we can establish this kind of database more efficiently and to use that to compare with some other landmark annotation methods like AI. So these are my talks for today. Thank you.
Thank you so much, Yuan. Really amazing presentation. Questions from the audience? If you do have any questions, please pop it in the Q&A. In the meantime, I will ask you some questions if you don't mind. Okay, so AI versus humans. I know you said in your findings that AI shouldn't replace doctors and things, but this deep learning, machine learning, deep learning algorithms are getting better. Once they're trained, they get better and better. So could AI potentially replace doctors in the near future?
Yeah, thank you. This is a very interesting question. From my view, since the medical field is evolving every day, so I like to split this knowledge into two parts. One is a lot more common medicine knowledge, which everyone's using it. So for this part of knowledge, I think AI can easily adopt them to replace part of at least to assist with part of the decision makings. So today I'm talking about the computer vision tasks, which is a little bit more advanced than, for example, the conversations using ChatGPT. So for the conversation-based clinical decision making, from my view as an engineer, I'm very optimistic that the AI will dominate more and more in this domain to firstly assist with clinical decision makings like consultations, to collect more data, to give you a more comprehensive suggestions. Either you need to see a more specialized clinical professionals, or you just take a few medicines and wait for a few hours, for example, like that. But for like the computer vision, we analyze the images. Currently, as I showed today, these outcomes were generated last year, which has not surpassed the doctor outcome yet. I know later it will improve. Eventually, they can replace part of the human work, but they are still an assistive role, so that the doctors can, like the surgeons, can save some of their time to let the computer do the automated tasks and maybe propose some suggestions, and surgeons can decide whether they want to proceed. But on the other hand, every day we have new knowledge coming in, a lot of medical papers fighting against each other, saying that this is better, this is worse, and this is new. So for this new knowledge, AI will never surpass a human. So I also think that the clinicians will be more and more innovative in diagnosis or treatment method, in inventing some new knowledge. These are something that AI haven't catch with the human clinicians.
Okay, it's a slightly related question. So when it comes to AI ethics, should we be concerned about potential threats in clinical environments?
Yeah. Other than clinical environment, we've actually had some good examples to show that AI already threats people's daily lives. For example, automatic driving. Sometimes they hit people and it could be fatal. If it's a human driver, we can clearly see it's easy to avoid that. But for computer, it's a different task, so computer can't really avoid that. But as a researcher, we talk with our data evidences. So we want to say that currently a lot of areas, including the AI-assisted clinical decision making, a lot of data shows that they are a lot more objective and a lot quicker, and shows a bit more empathy than human doctor as well. So in this domain, although no one can guarantee that it's 100% safe, there's always some failure, and sometimes it's very easy to identify failure. But in here, we can see that it's better to establish kind of mechanism to compensate with this AI failure. For example, using insurances, since the average failure rate will be eventually lower than clinicians. so that the insurance fee and coverage might be more preferable with the patient. So I think we can use some different mechanisms to avoid this kind of unsafe situations, to mitigate the medical concerns here using AI-assisted clinical decision making.
All right, cool. And now back to the nitty-gritty of your study. Was the effect of style of training sort of considered on the ability to identify landmarks?
Yeah, definitely. I think one of the interesting findings here is that some surgeons may eventually they learn a lot of knowledge, and some of them might already deviate from the large population, but they never knew, and they worked usually okay until an extreme outlier happens. So in our model, in landmark annotations, it provides us with the ability to identify that these like cognitive differences, they were trained differently, so that they can at least know that their learning might be slightly deviate from the large population, the large cohort of clinicians. And from there, they can try to be more averaged, or they can also propose that actually their diagnosis, for example, is more superior than others, so others need to go with the current outlier clinician. So I think there's always a balance in between, and it will generally evolve into a more favorable situation here.
Mm. All right. Thank you so much, Ian. Really lovely presentation. And before I close this webinar, can I say a huge thank you to all the amazing presenters we have had in this session today, and to every attendee as well for engaging with our presenters and for asking thought-provoking questions, particularly in the earlier presentations. And the webinar series still continues, and I believe the third webinar will hold in the United States early 2024. So I encourage you all to stay tuned for the next flyer. Thank you all so much for joining this webinar today, and I hope you enjoy the upcoming weekend. Thank you and bye-bye.
Thank you.
Thank you.